turn on the green button. Okay, once I get used to this technology, I love it, but getting it up and going is always a challenge. Okay, I know that you guys all have your brains elsewhere because you're thinking about the test, but you need to just let that all go, and let's get going on immunity, and then at the end we'll go over the exam. Okay, a couple of things besides discipline group 1. We'll meet at 1:30 at the coffee cart. We don't have a computer room to my knowledge right now. Please turn in your evals. Okay. And sorry for all the confusion that occurred with, because we had the colonoscopy on Monday with my husband. I was using my tablet grading all your stuff, which I really enjoyed doing, and it all worked out really well. But there was a few more steps and a few more glitches that came up as I started to send them back to you guys. So that was interesting, but it all worked out. Okay, so here we go. So first thing I want to talk about immunity is, first off, that there are constant updates. There are constantly more information that they're finding out about the immune system. And so it's constantly in flux. So what I'm going to be giving you today is really kind of a simplistic floor nurse sort of understanding of immunity, okay? Remember, there are multiple names. If you go to one book, it'll call it one thing, and in another book, it'll call it another thing, which is another reason to make us all crazy. When I first started prepping up on this lecture, it was like, oh my gosh, I had to start writing all the different terms that were being used that meant the same thing. That's one of the things in nursing that really annoys me, that they have so many same names for the same thing. So I've organized this to simplify and to help you focus your care. So let's look at the first thing. What is the definition of immunity? So the definition is it's the body's ability to destroy pathogens and prevent infection. Immune responses can be three different things. They can be immunocompetent, immunocompromised, or you can have a hypersensitivity reaction. So let's talk about immunocompetent, which is what I want, you want, we all want. It's a system that responds appropriately and destroys antigens. It's able to recognize itself and recognize its non-self. So it's not going to destroy itself. The thing is, autoimmune diseases can't do that. They do not properly recognize the non-self and self. It also depends on what we call tolerance. That means its ability to selectively attack some antigens and ignore and preserve body tissue and cells. Pretty smart, hey? So you can see why we get in trouble when our body isn't able to recognize that. Immunocompromised is going to be covered very extensively in 281, but basically this is a reduction of immune function that endangers the patient's health. Hypersensitivity reactions we're going to talk about at the end of this lecture, and this is basically where the immune system overreacts to an antigen and it causes harm to the patient. So we'll talk about the different types. There's like 5 different types of hypersensitivity reactions that are identified. So we're going to look at the 3 processes today that take part of immunity. One is the inflammatory response, the other is the cell-mediated response, antibody-mediated immunity. These are 3 different processes that are called many other things. Inflammatory response seems to stay about the same, but some books will call it natural immunity. Cell-mediated immunity is called cellular in some books, and the antibody-mediated immunity is called humoral in some books. Okay, so let's look at the first, and by the way, those 3 processes, they're all interdependent. They all overlap. They all react to one another and trigger one another. Okay, so let's look at the inflammatory response. This is also called natural immunity. This is where tissue damage is caused by a wound or by an invasion by a pathogenic organism, and it induces a complex series of events, and collectively they're known as the inflammatory response. So the goal of the inflammatory response is to wall off the infection, contain it, dilute it, and destroy that offending organism. It also wants to clean up and excavate the site of the inflammation, and ultimately we want it to heal. Let's look at the stages of the inflammatory response. There are, in some books they say 4, in I think Iggy it says 3 different stages. So we'll go by Iggy. Stage 1 is the, and remember the labels also of these stages vary from book to book. Trying to make us really crazy. But these stages are predictable. And the first stage is the vascular stage. This is an immediate response the body does when we have some kind of injury or invasion of pathogen. And so the injured tissue is going to cause histamine to be released, which is going to cause vasodilation. It's also, as this histamine is released, it's also going to cause capillary permeability. So when we look at the vasodilation, we know that now there's going to be increased blood flow to that area, and so there will be redness and warmth. That's one of the cardinal signs as we get farther down in this lecture, cardinal signs of inflammation. Also, as our capillary permeability occurs, we will see fluid being leaked into the tissue, and this will cause swelling or edema, and or same thing, edema. So, other things that happen during this stage is macrophages, or also known as monocytes, and neutrophils are going to flood into this area so that we can have phagocytosis, so they're going to start devouring what we need to get rid of. And they're also going to, by their coming to the area, they're going to stimulate the 2 other processes that we're going to study today, the antibody-mediated and the cell-mediated immunity. So we're going to see those 2 systems being triggered at this point. Going on to the next stage is stage 2, where there is cellular exudate. This exudate is really the result of white blood cells coming to the area, fluid from the damaged cells, and also necrotic tissue. So this is, we'll see this, and we're going to talk more specifically about exudate when we do wound care in about 2 weeks. Okay, so we'll talk real specifically. This will all link together. The third stage is tissue repair. This is where the cell tissue divides, or we result in cell tissue. And like I said, we're going to talk about all this in wound care. Question did you have? Or the cell tissue will either divide or scar tissue will develop. No problem. Okay, so now let's look at the different types of inflammation that can happen. We can have acute inflammation, and it can result into chronic inflammation. So acute inflammation is immediate. It produces local and systemic manifestations, and so those symptoms really depend on the location of the injury or invasion of pathogen or the extent of the injury. So really it can be very mild to very extensive, okay? So let's look at what are the cardinal signs and symptoms. Signs and symptoms of acute inflammation, the 5 cardinal signs and symptoms based on what we see happening in the body is warmth, redness, swelling, pain, and loss of function. Now granted, if it happens here in my thigh, the loss of function isn't going to be as great unless it's pretty extensive. But it could be a very small little paper cut on my knuckle, and that could cause me some real loss of function there. So it is really dependent on the location and the extent of the injury. But those are the 5 cardinal signs you do need. I would recommend that you do know those, not just for my test, but for NCLEX, 5 cardinal signs of inflammation. Other signs and symptoms we can see with inflammation is we can see fever, we can see tachycardia, we can see the lymph nodes enlarged, And we can also see cellulitis, which we see quite a bit up on the floors. We have a lot of patients that are admitted with cellulitis. Okay? And cellulitis is the inflammation extends into the surrounding connective tissue. Chronic inflammation, on the other hand, is an ongoing response. If the agent causes acute inflammation is not removed, then we may progress to a chronic stage, which can last anywhere from weeks to months to years. So the agents that can produce chronic inflammation include a irritant, non-living foreign material. And it cannot be removed by the body. And you know, we have lots of ways that our body removes foreign items. It can be removed by enzymes, it can be removed by phagocytosis, but for some reason we can't quite get rid of these. And a really simple, easy example of this is a splinter. A splinter will not be removed by the body. It has to kind of work its way out. So other examples would be something that was deliberately introduced, like a surgical prosthesis, sutures, things like that. And they're irritating the area. And that's one of the things we have to worry about when we do any of our surgical procedures and add a prosthesis. Will it irritate and cause more problems than what was originally the problem? So that's one of the things that they are always testing for before they start utilizing a prosthetic. And some people react to it and other people won't. Okay, another agent that can cause problems is an autoimmune disease. This is where, for whatever reasons, there's a stimulus that the normal, wait, what did I write here? Yeah, the disease process responds to its own tissue and acts as if it's not healthy and it wants to remove it, it reacts to it. So what we're going to see, this is different diseases such as lupus is a good example of a disease where it's reacting to its own body. Rheumatoid arthritis is another one. These are all going to be covered in 281. And then also we have infectious organisms that can continually irritate and inflame our body. A good example of this one is MRSA, where we can't quite get rid of it. Okay, so what can we do about this? So this is the whole thing. You know how I am about understanding what's going on with the patient, and all the things that we want to understand about what's going on with the patient motivate us and promote us to be able to provide specific care to our patients that is going to really help them. Not just throwing everything in the kitchen sink to try and help them. So what can we do to help them when they're having an inflammatory response, whether it's acute or it's chronic? Well, one of the things that we can do is we need to focus on promoting health. And so we can encourage them to rest. And these are things that when you are under attack and having an inflammatory response, should start putting into place. But for our patients that we have at the hospital, we definitely know we want to encourage them to rest. We want to encourage them to take fluids. We want to encourage them to have a well-balanced diet. We want to work on their nutrition. We want them to have a well-balanced diet that includes protein, carbohydrates, vitamins, and zinc are the main components that are urged for these patients. We really want to focus on the protein because most of our patients that are going into surgery have protein malnutrition. They said that in one study that 50% of all general surgical patients experience moderate to severe protein malnutrition. Wow, 50%. So that means most of your patients that you're taking care of are having a problem with their protein, and that will be reflected in their albumin. So what is a normal albumin? This should be part of your brain. Yeah, that's good, 3.5 to 5, which is an easy one because it's the same as potassium. Although some places like to say 3.5 to 5.5 for potassium, but I'll tell you, if I was a nurse and your potassium was 5.5, I would not be a happy girl. So 3.5 to 5, yes, good, remember that one. Okay. One of the things that we need to remember that when we have a good albumin, when our protein is normal, that also helps our phagocytosis to be more effective. So the immune system is impacted by our protein. And what did I write here? Pathophysiology. Well, inflammation causes catabolism. Remember, that's where the body tissues are being broken down. And so we want to be in anabolism, don't we? We want to be where the tissues are being built up. And so protein actually encourages and promotes this anabolism. And it encourages tissue healing, the production of antibodies, and WBC. So some good patho there telling you why we need to push them to eat their proteins. Now the problem is that sometimes they have other issues, don't they? And we have to kind of compromise on that protein intake. But in the ideal setting, we would want to do this, okay? Okay, going on. Medications. Well, what kind of medications would we want to give? Well, frankly, I wouldn't want to give any medications to a patient in a normal inflammatory response. But if the inflammatory response has become chronic or has become a problem for the patient, then there are some medications I would want to use, okay? And those medications are your anti-inflammatory and your analgesic agents, okay? So we would be looking at things like, I don't have it up here, but salicylates is a good one that we want to use. What is the other name for salicylates? Aspirin, and you should know that. That has to be in your brain for NCLEX because they will talk about salicylates, and if you don't know that it's aspirin, that can be a problem for you, okay? So make sure you know that grouping. Another group of medications that can help with the inflammatory response or to try and minimize it is the NSAIDs, your nonsteroidals. Also, corticosteroids are another great group of medications that also will help to suppress that inflammation. But, you know, we usually avoid them because we know that they do suppress the immune system and the inflammatory response. So we know that healing is not going to be as good. So we only go to these when we feel that the signs and symptoms of the inflammatory response are more than what we want, or are causing problems for our patients. But really, when I have, let's say, an injury, I really should stay away, or an invasion of pathogen, I should stay away from these meds if I can. But the reality is that when a patient comes into our hospital, they want to get rid of a lot of the symptoms that they have, and so we go with these medications. So, but always have in the back of your mind that they are also compromising our immune system. So try and go to another medication or avoid it if you can. Treat it with other ways. Let's see, what else? Antibiotics is another medication that we go with, and so of course we would want to, especially if it's something like MRSA or one of the other meds that it's a pathogen that we want to get rid of. But remember, before you start an antibiotic, what should you do? Always culture, or make sure the doctor truly doesn't want to culture it. So there's been many a time where I've called the doctor and said, do you want me to do a culture of this before we start this antibiotic? And after a while, you know which doctors will forget and which ones will remember, and so you don't have to remind them. Wound care is another thing that we will do to try and help this patient with that inflammatory response, and we'll cover that when we do wound cares in about 2 weeks. Okay, now this is my little cheat sheet. Every time I do anything that even slightly confuses me or even doesn't slightly confuse me, I make flow sheets and big, I just have to kind of draw it all out. Sometimes you'll see me just putting stuff all over the walls until I get it all together and then clean it up. So here we're going to look at the immune system components because we're going on to look at T cells, B cells, and all that. So let's look at the immune system components before we go into the cellular immunity or cell-mediated immunity. As you know, you remember that leukocytes also known as white blood cells. Some of you still do not have this clear. I know this because when I check your labs, you're mixing up platelets and red blood cells and white blood cells. It's really important that you understand the difference. And of course, this semester, we're going to be kind of tackling them so you can hopefully be very clear. If you aren't clear, go back to that section and try and get clear about it. But they are produced in your bone marrow, and we have 3 different types of leukocytes and WBCs, granulocytes, monocytes, and lymphocytes. Do you remember this from physiology? So much content in physiology, though. Whoa! Anyways, I think nursing's bad. I think physiology is even more content. So anyways, so when we look at this, these white cells are all very important. We're going to look at their different functions, but it's the lymphocytes that give us the T cells and the B cells that we're going to be talking about today. And also we have lying out there is the natural killer cells. So that's just an overview right there. So let's look at cell-mediated immunity, also known as cellular immunity. So what did I write here? It involves the T lymphocytes and the natural killer cells. The T cells are, I wrote a lot of this down this way because I know after the test you guys are like not absorbing anything. In fact, I've had some classes where I just take this lecture and put it up online. We can talk about that later because I know I've lost you completely. But anyways, T cells, so I write down a lot of this information up here because I know you won't see that as much on another lecture where I know there's not a test. So T cells are activated by phagocytosis. So we talked about that inflammatory response coming in and the neutrophils and the macrophages coming in, and the phagocytosis now triggers this to happen. So the T cells are now, hey, come on in here, let's take care of this. And so they actually do chemical destruction of any foreign invaders. They're pretty specific to fungi, parasites, viruses, cancers, and implants. We don't want them to go after the implants, but they can. The 3 most important, that's on my next slide. The 3 most important ones of these T cells, and I am simplifying this completely, is the helper cells, the suppressor cells, and the cytotoxins. Mainly, I really look at the helper and the suppressor cells, so let's talk about them. Helper cells, also known as CT4s, start the immune response, so they're notified by the inflammatory response, hey, come here. These T cells, the CD4s come in and start the immune response, and but one of the things that you'll need to remember about these, well, I'll come back to it. Okay, coming down. So that's what the CD4s do. Then the CD8s are what are called the suppressor T cells, and they slow down or stop the immune response. So it's obvious that we need CD4s to function properly and CD8s to function properly. Because if the CD4s keep on going forever and the CD8s don't come in and stop them, we've got a problem. And conversely is true, if we don't have enough CD4s, we're going to have a problem. And that's what I wanted to tell you about, is that CD4s are the T cells that HIV likes to attack. And this is why people with AIDS are so sick. I mean, just think about this. If this is your major cell that goes in and starts the immune response, and now you have some virus hiding inside them and destroying them, you can see why the problems that people with HIV have with all the opportunistic diseases killing them and harming them, okay? So real important to have CD4s and then, of course, the CD8s. CD8s slow down the response once the antigen has been destroyed, and they also prevent you from moving on to an autoimmune disease, okay? Your cytotoxins, which are a subclass of the CD8s, really like to go more after parasitic infections such as protozoa, but they also go after viruses, and they're really more specific than your natural killer T cells. So they're working on the side too. You can tell there's a lot of other cells I'm leaving out. So this is just kind of to give you an idea of how to function on the floor, and when you're thinking about what's going on. And if you work in an area, especially if you work with patients with HIV or any of the autoimmune diseases, you're going to get very involved in all these different types of cells and be an expert at that. But if you're a med-surg nurse on the floor, this is about as much as you need to know, okay? So natural killer cells are the CD16s, and they actually are what we call surveyors. They like to look around and find the viruses and the malignant cells, and they think that they're looking a lot more now at a lot of the cancers having problems with maybe some of these different cells not finding those malignancies, and other people having systems that really do find them and get rid of them, because we're constantly producing mutated cells. So why don't we all have cancer all the time? Because these cells take care of them most of the time. Why do they sometimes not? That's the big question. Okay, so on the next slide, I have a little picture that I stole from something online that I just like this one, where the helper T cells are calling the killer T cells, really, which is calling that's the natural killers, the NKs, and the macrophages to fight the infection. So really the macrophages are really there first, okay? So calling all killer T cells, we need more of you, so all the T cells are there fighting off infection. And then the helper T cells also activate the B cells, which we're going to talk about in just a minute when we talk about our antibody-mediated immunity. And so, okay, you B cells produce those antibodies. And then the last one, suppressor T cells, tell the B cells when the body can stop making antibodies. So now it says, okay, now you can stop. So let's stop. So it's a very interesting system, isn't it? Even on the most simplistic level, it is very interesting how it starts and stops and controls our system. So let's look at the other prong of our three processes, the third one, which is the antibody. And you'll notice that I put underlined there B to help you remember that antibody is the B cells, antibody-mediated immunity. I think, did I do something for the other one? No, didn't. Okay. So antibody-mediated immunity, also known as humoral in some books. This is where it involves the B lymphocytes. So the B lymphocytes are also activated by the phagocytosis, and also the T cells also activate them. And some of these B cells are going to change into memory cells. Memory cells quickly recognize a foreign antigen to which the body has been previously exposed. This is an essential element for us to acquire immunity. So what this means is that there are cells that change into memory cells from a contact with a pathogen, and they recognize that pathogen every time it comes back into our body, and will fight it. So for example, measles, we have measles. Our body fights it off. It makes a memory cell. The memory cell now knows how to fight that measles pathogen. So the next time that measles pathogen comes in, I don't get the disease because of this. And that's basically the principle of where immunizations are working from. It's based on us giving a small little bit of the disease, and you create these memory cells, and then when the real disease comes along, you're able to fight it off. Wonderful concept, you know. So anyways, so let's talk specifics. So the memory cells, the B cells, some of them change into memory cells. They recognize the foreign antigen, and they provide acquired immunity later against that disease. Some B cells change into plasma cells, and these plasma cells are going to produce antibodies and immunoglobulins and gamma globulins. Now, those particular things we'll use, some of them we use the gamma globulins, and the immunoglobulins we'll use for some immunity. We'll talk about that later. But the antibodies, each antibody is produced, is specific for one antigen. and it attaches to it and marking it for destruction. So we have a lot of different classes of them. I listed a few there, the IgM, IgG, IgA, but there's so many more. Okay?
Are these the ones, the cells that would react to, say, insect bites?
No, that's a hypersensitivity reaction. These are not the cells that you'll see reacting. I mean, the immune system does react, and each of the hypersensitive reactions has a different area of the immune response that is overreacting. Okay. So let's look at this is another one of my flow sheets to try and keep my brain straight. So you can see what I did is I said, okay, here's the lymphocytes, and here are my two main prongs of that, my cell-mediated and my antibody-mediated. When I look at the natural killer cells are off here doing their own thing, but coming down from the cell-mediated, I have my T cells. They also produce my helper cells, my suppressor cells, and my cytotoxin cells. Over here on my antibody-mediated, B cells, remember, B lymphocytes, and so they produce the plasma cells and the memory cells, and the plasma cells make the antibodies. And then, of course, they all kind of interrelate, don't they? Here, you'll see all these interconnections because it's not just some simple little process that cascades down. They all interrelate. And if this helps you, great. If it doesn't help you, go with what works for you, okay? Now, acquiring immunity, there's ways to acquire immunity. You can either have natural immunity, or you can have adaptive immunity. Now let's talk about natural immunity. Natural immunity is where, in some books they'll call it innate. Where they get, but anyways, we'll use natural. This is where there's natural barriers to infections or foreign substances in our bodies. So, for example, a natural barrier that we would see is the cilia in our nasal passages, how they bring the stuff up. Mucus is another one that brings the pathogens up. Earwax is another one. Things that we have naturally in our bodies that protect us. Gender-wise, men have a better protection against urinary tract infections because they have a long urethra. Conversely, we don't. Let's see some other things. Some ethnic groups have some advantages against certain diseases where other groups do not. And I talked about the physical barriers that we have, such as the cilia. Our skin is a barrier. The thing about these is they don't actually produce an immune response. There's no memory cells involved. There's no ability for the body to remember to fight off that particular pathogen. It just kind of is like a wall of a fort, kind of like, you know, it keeps things out, or it prevents things from getting in very easily. But it's not an immune response, okay? It's just a natural barrier. Other types of way to get immunity or to keep yourself from getting in trouble is adaptive immunity. And this is the one that we're going to talk most about. Okay. So adaptive immunity is acquired. It can be active or it can be passive. And so I'm going to talk about the different ways. This is where people get confused. And so what I did is I actually wrote this up here. We have natural ways to protect ourselves. We have active ways to protect ourselves. We have passive ways to protect ourselves. And then we're going to talk about under active, it's either naturally we can get it or artificially. Same thing under passively. We can get it either naturally or artificially. So let me keep on going, and hopefully it'll be clear to you by the time I finish. So when we look at active or passive, we're going to look first at the active group. So this is where the body actively responds with antibodies. And so when we look at the first group, naturally active immunity. This is produced by the individual after developing the disease. The plasma and the memory cells respond, and the result is protection from that disease at a later date. And the example I gave you earlier was measles, right? Mumps is another one. We get the disease. Our body creates the memory cells. It fights off the disease, creates the memory cells. The next time we get exposed to that disease, we do not get it. Okay? Natural, because we had the disease. Our body naturally created the immunity. Okay? So that's naturally active. Another way to get immunity is artificially active immunity. And this is when we give a person an immunization or a vaccination. Okay? So basically what we've done is we've given them the disease artificially, and now their body has created a response to it and created a way for them to recognize that disease. So the thing that's interesting about this is it's incapable of causing the disease, but the body responds to the organism, and antibodies are developed against that antigen, and then what ends up happening is we get protection that can last for years or a lifetime. And it depends on the type of immunization, on whether it's going to be a short-term protection or a long-term protection. Okay? So for example, polio. When we give the immunization for polio, we have given a very small amount of that disease to the patient, and then what we end up doing is the patient makes the organisms, makes the response to it, does not get the disease, which is the best thing about it, but now whenever they get exposed to polio, they will not get it. Okay? So artificially active. Okay? Let's look at the next type of immunity that can happen is passive immunity. This actually does not involve the immune response. It's basically just a transfer, okay? So naturally passive immunity, a great example of this is the fetus in the mom, where the fetus receives the mom's antibodies via the placenta, and it actually protects the infant for several months after the baby is born. So this is really a nice way where the mother transferred her antibodies to the baby to be able to protect that baby for a period of time, okay? That is naturally passive, just a transfer. Artificially passive immunity is a way to where we artificially donate antibodies such as gamma globulins, antivenom, and rabies vaccine. These are all artificially donated antibodies. For example, I got exposed to they thought I got exposed to one of the Heps B's because I kept on sticking myself at Children's. I worked at Children's, and they had the needle thing right here, okay? So we'd go and we'd put the thing in. Well, you know, I'm so compulsive. I got to put it down, you know? It can't be sticking up, but everybody else is letting it stick up. So by the time I hit the third stick, I learned things so quickly. I went down to the ED and got my gamma globulin shot to fight off that immediate, so they gave me a transfer of antibodies to fight that disease at that moment. Question whether it really worked at that time. But anyways, I digress. The thing about that is what they said to me, you do this one more time, you're fired. So I stopped pushing it down. You know, it was just so high I couldn't see whether it was sticking up or not. So be very careful. Now you'll notice they have the big, and so you drop it down so there's no chance of, used to be there with you'll see in the skills lab there a flap, and so sometimes some of them wouldn't go all the way down. So they have improved in that area. I guess there must be a few more of me's out there. So, so that gives you an artificially passive protection. So it's the protection is lost once the antibodies are used up, and so it can last weeks to months. So that is a artificially passive immunity. All right. Going on. Oh, here, I wrote it up another way. You can tell that this one kind of tormented me as I was creating it. I really had to write it up in 1,000 different ways to make it really clear to me. So hopefully these extra slides will help you to look and make it clearer for you. Okay? And here's another one. I just had to put another way to explain it to try and say, okay, this is active, this is passive, okay? And then finally, let's talk about immunizations. Immunizations. The thing that's really interesting about immunizations for me personally is that I gave immunizations for many years, many decades, and didn't really understand exactly what they were, okay? So yes, a lot of nurses out there are working with these items and they understand them generally. I'm going to give you a little more specific information. And it might help to clarify for some of you that like the detail, and for others of you like, I could have done with that information, but I'll give it to you anyways, because I've talked to a few of you now in my meetings, and some of you do like a little more detail. So, okay, definition, and the others are going, why did you say that? Okay, anyways, definition, this is a live or killed microorganism that will produce artificially active immunity against a specific organism. So the purpose is to induce long-lasting protection, but not produce the disease. When they came up with this, how wonderful. And we're talking about, this really was like in the 1940s, 50s that we actually got these really going, and what a difference it made in our lives. And I think that in your nursing career, you're going to see them coming up with vaccinations against the different cancers. And that will be what a jump that's going to be. That will be just change our whole lives. Okay? Unfortunately, we've done other things that have caused us problems. We'll talk about that next week. Anyways. All right. So there's different types of vaccinations or immunizations. So let's look at the different types. There is the inactivated, the live attenuated, and the toxoids. And you can see I pulled this over here to try and make it clear. So all of our artificially active immunity is going to be in these immunizations here. So what are the difference between these different types of vaccines? The inactivated vaccines provide a weaker immune response. So basically in inactivated, they've killed the virus, so it won't cause this disease, but what ends up happening is we actually have a much milder immune response. And an example of this particular immunization is our influenza. How often do we have to have our influenza done? Every year. Because they've killed the virus and we have a very mild immune response, and so we got to get it again the next year. Now granted, they do change some of the strains that they give you each year, but your response just doesn't last as long as we would like. Except for in the influenza, if the child gets the spray, that's a different type. That is actually a live virus. And so here we are looking at the live attenuated vaccines. They have been weakened through processing, so they can't produce the disease per se, but they are still live, okay? And that's why we're a little bit more cautious about our pregnant women giving any of those sprays to the children. So we try and keep them away. So that there's no problems. But it can't produce the disease, these live attenuated vaccines. The examples of these are MMR is a live attenuated vaccine, as well as the flu spray for the pediatric doses. Toxoids are another game altogether. Toxoids are a toxin that has been chemically detoxified without the loss of causing the immune response. And so these are for diseases that don't actually, you know how measles, it's the virus that causes the disease, but with diphtheria, tetanus, cholera, pertussis, it isn't the actual virus or bacteria that's causing the problem, it's the toxin that's causing the disease symptoms. So when we talk about C. diff, it's the toxins that cause the problem, so not the actual pathogen. So this is kind of interesting. So for some diseases, we're giving them the toxoid, okay? And the best example of these are going to be diphtheria, cholera, tetanus, and pertussis. And actually, they used to think that this would give us a long-lasting, but we're finding out with a lot of these ones, we have to get boosters down the road. Okay, side effects for these particular immunizations or vaccinations, local reactions we can get and systemic reactions. Local reactions that we can get are redness or swelling, and so you'll see here, I don't know if you can see it here how red that is, but I got one right there. That's my shingles vaccine. It's red right there. I was kind of surprised. But anyways, it's just a reaction, inflammatory response right to the site. One of the things that we do encourage when you give a vaccine is that you give it in the dominant arm. The reason being is that we know that you're going to be moving that arm, so there will be better absorption. And then, of course, we also many times will tell people, go ahead and take some Tylenol to try and minimize that reaction if it's bothering you. Okay? And we do that a lot with our peds patients when we give them the huge run of a bunch. We'll give them a Tylenol because we know they're going to have that inflammatory response. Is that a good thing to do? I did it as a mother to make my baby happy. Systemic reactions that we can see, and of course Tylenol, we remember the other name for it. Systemic reactions that we can have for our patients is fever, malaise. They can actually, some of our patients have vasovagal reactions. That happens right as we give the shot. What were the percentages? Did I write it down here? Yeah, about 40% of the patients that are between the ages of 10 and 18 it will happen to. Typically, it's like your 16-year-old guy who does not want to faint in front of everybody, and they will. And really what it is that we give the shot and they do a vasovagal. When you press down on your vagus nerve, what happens to your heart rate? It drops, that's right, and they drop too. It's one of the best ones I ever see where they call a code, and then the patient walks out 20 minutes later. Always better to guess the worst consequence. But we've done this a few times where the patient they just go right down fast. Their heart rate drops on them completely. And then, they're right back up and going afterwards. So that's why we like our patients sitting down when we give them the vaccination. And we like to have them stay around because it can happen anywhere to 5 to 20 minutes after you give the injection. Usually it happens right after you give it. But 5 to 20, so that's why we say they should stay. How many of you have your practitioners having you stay? I'd say probably none of you have them having you stay, but in reality, you should be staying because of the vasovagal, but also you could have anaphylaxis, which is our last one there, and really a worrisome one. This is where they get itching, shortness of breath, wheezing, and literally their whole body shuts down. We'll talk about that under hypersensitivity reactions. The treatment for this particular problem is that we should give them epinephrine. It should be the 1 to 1,000. I got to stop talking in a minute here. You know what I'm going to do? I'm going to stop here and I'm going to come back to you guys and talk about anaphylaxis. Otherwise, I'm going to be rushing myself through this, okay? So we'll stop right here and I'll come back and start talking about that when we come back next week. Let me mark this here. Okay. All right. So let's go over